So, hello everyone. So, we have just dropped one gentle reminder to sir. So, probably he'll be joining. Might be some glitch from his side. Yes, sir has just joined. Yeah. Very good evening to you, sir.
Good morning. Good evening to you.
Yeah.
Professor Ralph, very good morning. Ashok here. Delighted to meet you.
My pleasure. What
How are
time is
you,
it
sir?
in India?
7:28. 7:28
7:38.
EM.
Okay. So you're getting ready for evening. I'm getting ready for waking up.
Good.
No, actually, I've already done an hour of my exercises, so I'm ready to go.
Oh, good. We'll
That's
start in a
great,
couple
sir.
of minutes. Abhishek, we'll start in a couple of minutes. Abhishek.
So, we have with us our speakers as well, sir. Bipin Sethi, sir, and JB Kanwar, sir, will be having their sessions today
Good.
evening. And so we have moderators from all the 13 different physical centers pan India across. So they have a very crucial role to play with respect to all the questions that they'll be getting from all the delegates, and hence they'll be all be very eager to interact with you in the awaited panel discussion towards the end.
Okay.
Yes. So, sir, like we'll begin in a couple of minutes, wherein I'll be just opening, and then I'll hand it over to Ekedas sir to take ahead the proceedings.
So,
Okay,
Dr.
you
Abhishek,
see-
you can go through centers once very quickly and introducing the model very quickly.
Yes, yes,
I think that's a
Sure.
good idea.
yes. So, sir, from Hyderabad, we have KVS Hari Kumar, sir.
Hello, sir.
Hello.
Sorry.
Then, sir, coming to Mumbai, we have Manoj Chadda, sir, here. Sir, can you hear us? Manoj Chadda, sir. Then, sir, from Chennai, we have Jayashree Gopal, madam, who is joining us.
Hello, sir. Good evening.
Hello.
Sir, then from Cochin, we have Dr. Vipin VP, who will be joining us.
Joined already. Vipin is
Yes.
Vipin is already there.
Yes, sir. Then from Kolkata, we have Dr. Salil Pal, sir.
Hello.
Hi.
Hello, sir.
So from Bangalore, we have Dr. Parmesh.
Good evening, Dr. Differenzo, Dr. Parmesh here.
Good evening. Oh, good morning from here.
From Lucknow, we have Dr. CG Agrawal, sir.
Good evening and good morning, Dr. Franjo.
Good
And
morning.
We are all set to hear you.
Good.
Okay, sir, from Guwahati, we have Dr. Manas Barua, sir.
Good evening.
Good
Welcome,
evening.
Professor.
Manas, good evening. Welcome again.
Yes. So from Rajkot, we have Dr. Pankaj Patel, sir.
Pankaj is joined.
Rajkot Center.
Yeah, they should be connected in the moment.
Yes,
We can
yeah.
go ahead.
Okay. So, sir, from Jaipur, we have Dr. Shailesh Loda, sir. From Delhi Center, we have Dr. Sunil Kohli, sir.
Good morning, Dr. DeFranzo.
Hello.
Looking forward to your talk.
Thank you.
From Bhubaneswar, we have Dr. J. Kishore, sir.
Namaste, Dr. DeFranzo, and good morning to you.
Yes, sir. And then we have our very esteemed chairperson, Dr. A.K. Das, sir.
Thank you. Thank you. Thank you. I'm there. Thank you. Thank you. Thank
We
you.
also have with us, sir, Dr. Hanuman Barkate, sir, who is, and Dr. Sachin Suryanshi, sir.
Good morning, Dr. DeFranzo. Good morning, Dr. Deepansh.
Good morning.
And we have Mr. Amit Ajmera, sir, and Mr. Ajay Kapoor, sir, from Glenmark Marketing Division.
Good morning, sir.
Good morning, Amit.
Everybody
Good
is
morning.
eagerly looking forward to your talk and interaction today.
Okay. Sounds like you got every major city in India.
There are
Yes, sir,
still 13 of them.
I know. Great job.
Yeah,
Yes.
really, I agree with you, Professor Diffranjo. Great job.
So, Dr. Abhishek, we can then go ahead with our schedule.
Abhishek sir?
Yes, definitely. So, is this Dinesh from Mumbai Center?
Yeah. Abhishek sir, I will give a countdown 5, 4, 3, 2, 1, then we can start.
Okay,
So we are
sure,
ready?
sure.
We are ready to start?
Yeah, definitely.
5, 4, 3, 2, 1, live sir.
Okay. So, hello everyone, and a very good evening to one and all. I, Dr. Abhishek Mane, along with Dr. Sachin Suryavanshi, General Manager, and Dr. Hanman Barkade, Senior Vice President and Global Head, Global Medical Affairs from Glenmark Pharmaceuticals, would like to welcome you all to meet the legend himself, Dr. Ralph A. DiFronzo, sir, version 2.0, a mega digital event with around 9,000 registrations, wherein delegates will be participating both via the physical mode as well as across 13 different cities pan-India. We all know that diabetes is a chronic metabolic disorder having global presence, but more so in the Indian subcontinent. Therefore, addressing patient needs becomes very important. With this perspective, we have aligned our today's program with the organoprotective theme that has been rolled out by the ADA ESD consensus titled Strengthening Diabetes Management with Organoprotective Medications. It is indeed our privilege to interact with the legend himself, Dr. Ralph A. DiFronzo, sir, the father of Omnius Octet. We have our distinguished chairperson for the evening, Dr. A.K. Das, sir, along with our eminent speakers, Dr. Bipin Sethi, sir, and Dr. J.B. Kanwar, sir. Can we have the next slides, please? Yeah. So these are our eminent panelists, Dr. Ralph DiFronzo, sir, Dr. A.K. Das, sir, who will be our chairperson for the evening, Dr. Bipin Kumar Sethi, sir, and Dr. J.B. Kanwar, sir, who will be our speakers. Next slide, please. Next slide, please. Okay, now let me quickly take you through the agenda for our today's evening. We'll be having our opening remarks by Professor A.K. Das. Followed by this, we'll be having our first scientific session by Dr. Bipin Sethi, sir, which is leading T2DM management, biosimilar GLP-1. After this, we'll be having another scientific session by Dr. J.B. Kanwar, sir, which will be addressing the core effect on insulin resistance. Following this, we have the legend himself, Dr. Ralph A. DiFronzo, sir, and his views on organoprotection in diabetes management. After this, we have the most awaited panel discussion, wherein we'll be inviting all the 4 dignitaries and we'll be having questions from all the different 13 centers pan-India. This will be followed by vote of thanks. Next slide. Now, in addition to all the distinguished speakers and the chairpersons, we have our eminent and expert moderators who will be joining us physically from 13 centers across India. Now, these moderators will play an extremely crucial role of not only representing that respective center, but also will be the voice of the delegates present over there. So, let me introduce to you one by one. So, from Bangalore, we have Dr. Parmesh, sir. From Bhubaneswar, we have Dr. J. Kishore, sir. From Chennai, we have Dr. Jayashri Gopal, madam. From Jaipur, we have Dr. Shailesh Loda, sir. From Kolkata, we have Salil Kumar Pal, sir. From Lucknow, we have C.G. Agrawal, sir. Next slide. From Cochin, we have Dr. Vipin, sir. From Delhi, we have Dr. Sunil Kohli, sir. From Guwahati, Dr. Manas Barua, sir. From Hyderabad, we have Dr. KVS Harikumar, sir. From Mumbai, we have Manoj Chadha, sir. From Nagpur, we have Pramod Gandhi, sir. And from Rajkot, we have Pankaj Patel, sir. Okay, now let me take this opportunity to introduce to you our esteemed chairperson for the evening, Dr. A.K. Das, sir. I know there's no need of any introduction for A.K. Das, sir, but it is my pleasure and opportunity to introduce him in front of everyone. Yes, can we have his slide? Yes. So, A.K. Das, sir, has a spanning experience of more than 45 years in clinical practice. He is the Professor of Eminence, MGM CRI, and Dean of Academic Staff, SBV. He is the former Director Professor of Medicine and Medical Superintendent Dean at JIPMER, Pondicherry. In addition to this, he has a feather in his cap of being the Additional Director General of Health Services, Government of India. He has been the Professor of Medicine at Pondicherry Institute of Medical Sciences, Pondicherry. He has also been the Consultant Diabetologist at London, Sweden, and Mayo Clinic, Rochester. Also, he has an opportunity to be the past National President at API, RSSDI, and Dean, Indian College of Physicians. And to this, he has to his credit over 193 publications in both international as well as national journal. We heartfully welcome you, sir, for this session and program. From here, I may now request Dr. A.K. Das, sir, to kindly take the proceedings. The stage is all yours, sir.
Abhishek, thank you very much for this great, kind introduction and giving me this great opportunity to preside over this great meeting with the difference, the convents with the difference, which is set around practice change, set around giving the directives. How do we practice diabetes tomorrow? Glucocentric to adipocentric, and today to organ protection. And it is very important to remember that the ravages of diabetes are great ravages, but we call it relentless ravages of diabetes. But Professor DiFronzo, through his various work, and my eminent colleagues from India, Bipin, JB, and all the 13 people who are here today have, through their great work, have also shown the advances in diabetes is equally relentless. Therefore, today, even though we know the diabetes affects from head to toe, from hair to the nail, we today have the means in our armamentarium, tools in our hands to provide organ protection in diabetes mellitus. I call it, Professor DiFronzo, I call it the most important contemporary challenge. Why I call it so? Because diabetes is a sweet disease, but with a sour company. What is the sour company? The affection of the various organs because of diabetes mellitus. And today, we know that we can provide cardionephroprotection, we can provide hepatoprotection, we can provide protection for the cerebral stroke and also peripheral arterial disease, and we can provide protection for most of the things, whether it is gut dysbiosis, whether it is mitochondrial dysfunction, there are many other things. So therefore, today's topic is most important and contemporary. Before I invite Professor Dr. Bipin Sethi, I must tell you, the meeting assumes great importance for two reasons. Number one reason, Ralph, because of you. You have given year after year the way we should move in diabetes. You have been always interested in providing to us the root cause of diabetes and how do we address it. The pathophysiology of diabetes, how do we address it? Whether it is resistance, insulin resistance, whether it's secretory defect, whether it is the various ominous octet, whether it is the SGLT2 secreting urine, the glucose in the urine, you have been the father of that. So your presence makes it great. I heartily, on my own behalf, on behalf of the Pan India, welcome you, Ralph, for this great meeting. Dear friends, we have amidst us someone who is different, who is great, and he is my very close friend, a national icon in diabetes and endocrinology, Dr. Professor Bipin Kumar Sethi, MD and DM from Chandigarh. Dear friend, he has got clinical experience of over 35 years. And his practice has one of the best practice setting, best clinic setting, best practice setting in the country. Today, he is the consultant nephrologist and head of the department at Care Hospital in the Banjara Hills, Hyderabad. And he is live member of ESI, of the RSSDI, 56 publications, principal investigator of over 60 national and international clinical trials, and he has been one of the inspiring doctors voted in the Economic Times in 2018. Above that, Bipin's grasp of the subject, twinning it own clinical experience, and presented to us one of the greatest assets that he has. Dear friends, he is going to speak to us on a very, very important topic, leadering type 2 diabetes management with GLP-1RA, which has been given the title, the molecule of the decade. And the recent guideline, you will find GLP-1RA has assumed a very supreme position. Dear friends, I have great pleasure inviting Bipin and requesting him to present his lecture. Bipin, all is yours.
Thank you, Professor Das, for those kind words. The topic allocated to me is leading type 2 diabetes management with GLP-1 analogs. And we are all aware about the global epidemic of which India and Southeast Asia are a part of. And for this august audience, I need not tell that the number of diabetics that we have in our country are presently quite large, and they are going to increase further in year 2045 as per the IDF Atlas. The American Diabetic Association and the European Association for the Study of Diabetes has come out with a consensus statement in 2022, which talks about the placement of GLP-1 analogs in specific segments for optimal management of diabetics. GLP-1 analogs are indicated in patients with established atherosclerotic cardiovascular disease or those with risk factors for atherosclerotic cardiovascular disease, which means people above 55 with at least two of the risk factors like obesity, hypertension, dyslipidemia, smoking. They also have a role to play largely for glycemic control and cardiovascular protection in patients with CKD, and their role in this disease and heart failure not so clearly well established. They have a role to play for controlling glycemia without producing hypoglycemia. And also they have significant impact on weight loss, and they are one of the more potent agents towards this effect, which many anti-hyperglycemic drugs lack. GLP-1 analogs basically have many actions, but their actions on the glucose regulation depend on the capacity of the GLP to regulate T2 players in the glucose metabolism, as in they produce glucose-dependent improvement in insulin secretion and glucose-dependent decrease in glucagon secretion, resulting in improved glycemic control. The liraglutide has been there in management of diabetes for quite some time. It's an agent that improves glycemic control, and as mentioned earlier, it's associated with weight loss, has beneficial impact on lipid profile largely driven by a decrease in triglycerides, and it has reduction in blood pressure, which is to the tune of about 5 millimeters of systolic blood pressure. It has cardioprotective and renoprotective properties. In the landmark leader trial, which was the impact of studying this drug in cardiovascular outcomes in type 2 diabetics, it was found that the primary endpoint, the reduction in the major cardiovascular event, was to the tune of 13%, and also there was a decrease in the death from cardiovascular causes. If you look at the impact on MACE by various GLP-1 receptor analogs, you find that liraglutide alongside semaglutide and albiglutide does reduce 3-point MACE, and the similar impact is seen with dulaglutide. If you look at the renal outcomes are primarily driven by reduction in albuminuria, and you find that there is an overall impact of reduction in albuminuria by all GLP-1 analogs, and liraglutide, as studied in the leader, was also having this impact. If you compare the available GLP-1 analogs, starting with liraglutide in question, which we're talking about, this is a once daily drug, which can be started at 0.6 milligrams, up titrated to 1.2, further up titrated to 1.8. It is indicated in patients with type 2 diabetes mellitus, patients with established atherosclerotic cardiovascular disease, and it's other version is also indicated for management of obesity. Dulaglutide is indicated similarly in patients with type 2 diabetes mellitus with atherosclerotic cardiovascular disease. Oral semaglutide, which is available in the country for about a year plus, is indicated in the management of type 2 diabetes mellitus and has got yet a study going in Seoul, which will tell whether it has an impact on cardiovascular disease or not. So one has this lacunae with this oral semaglutide. Injectable semaglutide, of course, is having similar indication to liraglutide, but it's not available in our country. The advantages of these molecules are, of course, beyond the glycemic control, that they do produce weight loss, they produce reduction in the blood pressure, and as talked to you earlier, there are indications for reduction in MACE and for liraglutide reduction in mortality. The major disadvantage with these molecules is that most of them, the ones who have shown impact on cardiovascular disease, are available as injectable or not available, as is the case for oral injectable semaglutide. They also differ in frequency of administration. Dulaglutide has to be given once a week. Injectable semaglutide has to be given once a week, whereas liraglutide has to be given once every day. This could be viewed as an advantage also because the drug's side effects are for the duration of the injection. If you are taking an injection every day, then you can obviously avoid the side effects should they occur by simply omitting the drug, whereas that's not going to happen for once a week preparations. The major barriers to GLP-1 analog usage across the world, not just in our country, is the cost. All are aware of its very potent HbA1c lowering efficacy, predictable weight reduction, good safety profile, favorable CV data, and convenient administration once a day. But the issue there is the cost. And many people who are otherwise candidates for its usage are not able to get the full advantage of this on account of the medication's cost. We then come to how the cost can be reduced. And we are aware in the field of insulin and many other molecules that there are biosimilars which are introduced into the market upon the lapse of patency of the parent or originator molecule. The definition of biosimilar by WHO is a product which is a biotherapeutic product which is similar in terms of quality, safety, and efficacy to an already licensed product. There are, of course, different definitions by the EME and also by the FDA. By and large, most regulatory bodies recommend a stepwise approach to demonstrate biosimilarity between biosimilar and the reference biologic products in terms of safety, potency, and purity. Largely, it is not about efficacy, it's also about antigenicity of a molecule that has to be demonstrated before one can say that this can be safely administered. So the regulatory pathways for biosimilars are having some differences and some similarities with the originator. The originator has to do many studies in terms of molecule characterization, non-clinical studies, phase 1 clinical studies, and then go to phase 2 and phase 3. Whereas the biosimilars do not have to go through all this because the molecule has been already characterized. They have to only show that the drug is efficacious, it is as safe, and does not have any issues because it is being produced in some other manner or fashion. The cost of therapy, therefore, is much cheaper for the biosimilars because they do not have to go through the whole gamut of tests or test procedures which the original molecule has gone through. It's often difficult to spot the differences, and you see in the newspapers pictures, spot 5 differences between this diagram and that picture. Sometimes it is not easy, and that's how a biosimilar should be. It should be almost similar in composition, constitution, and therefore have similar efficacy on the biological system that is human body when it's introduced into that. Biosimilar development program is obviously a very major program because many countries cannot afford these molecules, and once there's lapse in patency, it is not unique to our country, but many other countries also have their own biosimilar development programs. The patient can reach to the physician and get the same product that the biological reference range was, to have the benefit and the outcomes which the molecule is associated with. The benefits obviously basically are the affordability of the drug, and it increases the drug access. However, what is more important is that one has to be sure that it is not just cheaper, but also safe. And currently, there are many molecules, as you know, like Simplargin, which have been manufactured in this way, and biosimilar liraglutide, luckily for us, is also in advanced stage of development and awaiting regulatory approach. So in summary, GLP-1 receptor agonists have come a long way since their introduction, because they're with small or short half-life GLP-1 analogs required to be administered subcutaneously, mostly in an injectable manner, and they are promising agents for not just glycemic control, but with additional advantages of reaching target without hypoglycemia and without weight gain. GLP-1 analogs, as we've seen, they also cause consistent weight reduction and have data in reduction of MACE, as also some reduction in proteinuria. Though in proteinuric cases, one would be giving the SGLT2 inhibitors first, but for offering additional glycemic benefit, which does not occur at lower GFRs for patients with SGLT2 inhibitors, one would require GLP-1 analogs, and that's where they fit in by the KDIGO guidelines. Also, after metformin and SGLT2 inhibitors, these drugs have a greater role for preventing the associated atherosclerotic cardiovascular disease. Oral route of administration offers some of the advantages, but the molecule in question has not completed the CV outcome trials. As for now, we have only injectable agents to offer the benefit of MACE reduction, and cost being another limiting factor is hopefully going to be taken care of by biosimilars. Thank you very much for your patient hearing. Thank you, Professor Das, once again.
Bipin, thank you very much for a very, very brief, at the same time, all-inclusive talk highlighting the great benefits of this great molecule. The GLP-1R, how does it affect the hypothalamic neurons for the satiety, weight loss, and most important, as you rightly said, the robust and consistent cardiovascular benefits, its impact on the weight loss and lipids. I think I will not have time to describe, but I must tell you, it's a great talk highlighting all the aspects of GLP-1RA. And we'll have questions at the end of Professor Ralph's talk. It's now my duty to invite Professor Dr. J.B. Kanwar from Bhubaneswar. And, he has been the professor and head of endocrinology at the famous Institute of Medical Sciences and the Sikhya Anushandhan Hospital, Shom Hospital at Bhubaneswar. He is a reviewer of the papers for the IJEM. He has more than 20 scientific publications in peer-reviewed national, international journals. He has been the past secretary of the Odisha Endocrine Society and has organized state-of-the-art conferences. JB, we all remember that, what you have contributed, and many, many national and state conferences. Dear friends, he is going to speak another very important issue, which is key to type 2 diabetes management. He is going to talk to us, how do we address the core defect of insulin resistance, which is a paramount important Indian population, and how do we address this insulin resistance in type 2 diabetes mellitus with combination therapy. And that's a great thing. And without wasting any time, it's my great pleasure, JB, we call him JB in the short form, JB, to hand over the forum to you for your phenomenal talk. Over to JB.
Good evening, friends. Thank you, Ashok sir, for your nice and kind words. I'll be speaking on targeting the core defect of diabetes with novel combination of teneligliptin, pioglitazone, and metformin combination. As you all know that Indian diabetes are different from Caucasian diabetes. We tend to develop diabetes at a younger age and with lesser obesity. And this is primarily attributed to the visceral fat content. We do have higher visceral fat content leading to higher insulin resistance. And this high insulin resistance is a major concern in patients with type 2 diabetes in Indian population. Recently, five distinct clusters of diabetes with significantly different characteristic has been found in Scandinavian population, and depending on different parameters of insulin secretion, insulin resistance, and some of the other clinical parameters. I have shown those different spectrums of types of diabetes. I can see the severe insulin resistant diabetes is one of the clusters of among those five clusters, and that attributes about 15% of type 2 diabetes in Scandinavian population. Similarly, in India, in INSPIRED study, they identified four distinct clusters of type 2 diabetes in Asian Indians. They studied about 19,000 odd patients in 50 diabetes centers across nine states of India. And they had four spectrum, two are similar kind with Scandinavian population, but they had two different spectrums like insulin resistance, obese diabetes, that is IROD, that was found in about 26% of the type 2 diabetes patient, and combined insulin resistance and deficient diabetes, about 12% of the type 2 diabetes patient. So in Indian population, high insulin resistance constitute about 38% of the type 2 diabetes patient. And we all know that thiazolidinediones are most potent antidiabetic to address insulin resistance. As far as the ADA-ESD consensus report is concerned, that they have recommended thiazolidinediones as a treatment of diabetes in patients with established atherosclerotic cardiovascular disease, or in those patients with type 2 diabetes with high risk of cardiovascular disease. However, they have placed thiazolidinediones after GLP-1 RA and SGLT2 inhibitor. They have also recommended thiazolidinediones as a highly effective anti-diabetic agent as far as HbA1c reduction is concerned. So thiazolidinediones are recommended as organ protective drugs. If you look at the core defects in type 2 diabetes, the beta cell function and insulin resistance are due to primary pathophysiological mechanism leading to hyperglycemia. We all know that that DP4 inhibitor that increases the insulin sensitivity, that increases insulin secretion. That animal studies have shown that DP4 inhibitor can preserve the histological architecture of pancreatic islet cell as well as beta cell mass and function in response to number of stress conditions. And we also know that pioglitazone has also been shown in vitro and vitro studies that also protect the beta cell. So sitagliptin, which is a DP4 inhibitor that improves beta cell sensitivity, and pioglitazone and metformin reduces insulin resistance. There has been animal and human studies of combining DP4 inhibitor and pioglitazone, and in mutant obese mice, when DP4 inhibitor and pioglitazone combination have been used, and in those mutants, mice studies have shown that increases, both combination of these drugs increases in plasma insulin by threefold and increases intrapancreatic insulin content by about 2%. So both these combinations improve the insulin sensitivity and also increases the insulin secretion and preserve the beta cell. Coming to sitagliptin, pioglitazone, and metformin combination, the pioglitazone that reduces the gluconeogenesis by improving hepatic insulin sensitivity, enhancing the insulin-mediated glucose utilization in the peripheral tissue, and restraining lipolysis. Similarly, DP4 inhibitor that enhances insulin secretion and suppresses glucagon release. By suppressing the glucagon level, it alters the insulin-glucagon ratio in the portal vein, which reduces the hormonal stimulus for the gluconeogenesis or hepatic glucose output. Sitagliptin, which is extensively used in India and has significant and clinically meaningful reduction in HbA1c and postprandial glucose in Indian patients with type 2 diabetes. There has been plenty of evidences as far as the effectiveness and safety with the 10-ligliftin. Recently published top TIS study where they looked into the effect of 10-ligliftin on glycemic variability by CGMS. They found that 10-ligliftin reduces the glycemic variability and it significantly improved TIR, TAR, and HbA1c at the end of the study. There is good real-world data by Treat India and Treat India 2 study which showed that 10-ligliftin either as a monotherapy or as an add-on to more commonly prescribed anti-diabetic agents significantly improved glycemic parameter. There is concern about prolongation of QT interval with 10-ligliftin. However, this aspect has been studied with the QSET2 in Indian type 2 diabetes patient. There were about more than 800 Indian type 2 diabetes patients where 10-ligliftin was started with 20 milligram and after titration was done up to 40 milligram. And the study that didn't find any QT prolongation in Indian type 2 diabetes patient. In switchover study, those patients who are inadequately controlled on other DP4 inhibitor, when they were switched to 10-ligliftin, there was further significant reduction in the HbA1c level. Pioglitazone is a good potent anti-diabetic agents and insulin sensitizer, and RSSD recommends that in presence of insulin resistance, addition of thiazolidine can be considered along with metformin. There are good evidence that as far as the cardiovascular risk reduction with pioglitazone is concerned, the proactive study which was done in type 2 diabetes with established macrovascular event that showed there is significant relative risk reduction in risk of fatal, non-fatal myocardial infarction, reduction in the composite CV death, non-fatal myocardial infarction, non-fatal stroke, and pioglitazone can reduce the risk of secondary macrovascular event in high-risk type 2 diabetes patients with established macrovascular disease, particularly in stroke. Risk reduction is concerned. That led to initiation of IRIS trial, where the IRIS trial was done in non-diabetic patient with recent history of stroke and transient ischemic attack. That showed that pioglitazone reduces the further risk of stroke and myocardial infarction. And Chicago trial showed that pioglitazone slowed the progression of carotid artery intima medial thickness compared to the glimepiride. This is a meta-analysis with all the pioglitazone. About that, they included about 26 RCTs with pioglitazone. They found 20% reduction in the risk of MACE and 20% reduction of the non-fatal myocardial infarction and 19% reduction in non-fatal stroke. The conclusion was pioglitazone should be considered for prevention of the cardiovascular event. There are lots of studies with the DP4 inhibitor along with pioglitazone. Pioglitazone has been studied with the sitagliptin, the linagliptin, as well as with the 10-ligliftin. And Dr. Differenzo published his pioneer paper where he, in 2012, he studied pioglitazone allogliptin about in 1,500 odd type 2 diabetes patient. He used allogliptin and various doses of allogliptin along with various doses of pioglitazone in fixed dose combination, and he found that allogliptin pioglitazone combination significantly reduced HbA1c as compared to the pioglitazone alone. Similarly, Konda, he showed in Japanese patient that 10-ligliftin and pioglitazone combination significantly reduced HbA1c. So this is Indian data of 10-ligliftin pioglitazone on the background of metformin. This is a phase 3 prospective randomized double-blind comparative, including about 15 odd centers where the studies were done of 24-week duration. In the first test group of the diabetic patient were given fixed dose combination of 10-ligliftin 20 milligram along with pioglitazone 15 milligram. In the second test group, diabetic patients were given 10-ligliftin 20 milligram along with pioglitazone 30 milligram. They were compared with the monotherapy of 10-ligliftin 20 milligram and pioglitazone 30 milligram. Those patients were already on background therapy with metformin 1 gram daily for more than 3 months duration. Still, the HbA1c was uncontrolled. The primary efficacy endpoint was change. Time. And the blue bar that denotes 10-ligliftin 20 milligram and pioglitazone 15 milligram, that clearly showed that mean reduction of HbA1c of minus 1.32% at 12-week time On right-hand panel, you can see about in 24-week time, at the end of the trial, there was a mean HbA1c reduction of about 1.36% in 10-ligliptin 20 milligram and pioglitazone 15 milligram group. Coming to the secondary endpoint, the fasting blood sugar and postprandial blood sugar, the green bar that denotes 10-ligliptin and pioglitazone 15 milligram, that significantly reduced fasting blood sugar by 38 milligram per deciliter, and postprandial blood sugar was significantly reduced by 76 milligram per deciliter. And the target HbA1c was achieved in 47% those who received 10-ligliptin and pioglitazone 15 milligram. And there is significant improvement in glycemic control in this phase 3 study. The combination was well tolerated. And the conclusion was that in phase 3 study of 10-ligliptin pioglitazone on the background of metformin that has shown significant improvement in glycemic control in Indian type 2 diabetes patients, there was no increased risk of hypoglycemia. And top tier studies show there is reduced glycemic variability. The core defect of insulin resistant beta cell dysfunction are addressed by combining both this 10-ligliptin and pioglitazone, and will be a promising combination for uncontrolled type 2 diabetes patient with high insulin resistance. So 10-ligliptin along with pioglitazone and 10-ligliptin along with pioglitazone and metformin will be an important addition in the armamentarium of diabetes management. Thank you.
Thank you, JB, for a very effective discourse on the insulin resistance, the core defect. And as you rightly said, 40% of the type 2 Indian diabetics are IR, and we have wonderful combination. You alluded to PIO, Teneli, PIO plus MET, and showed the results, the proof of the pudding, how it is great and how it produces great change. Teneli is the maximally used gliptin in our country, Professor DeFranjo, from the DCGI data, Government of India data. And and metformin, we started using very early, and you took it to USA in 1995, and PIO, the story is known to everybody. Therefore, dear friends, a great talk. We'll come back to the questions a little later. But now, dear friends, it is my great honor and pleasure to invite somebody who is a moving encyclopedia and who has made a great change in the practice of diabetology. He is Dr. Ralph Anthony DeFranjo, Professor of Medicine and Chief of the Diabetes Division at the University of Texas Healthcare Center and the Deputy Director of the Texas Diabetes Institute, San Antonio. Now, his major interest has been focused on the pathogenesis and treatment of type 2 diabetes and the central role of insulin resistance in the metabolism, in the metabolic diseases and the cardiovascular diseases, in the cluster of metabolic cardiovascular diseases known collectively as IRS, insulin resistance syndrome. Dear friends, Professor Ralph DeFranjo has the unique distinction, having been specialized in internal medicine, in endocrinology, believe me, dear friend, also in nephrology, winner of many awards. I'll just cite few, starting from the Eli Lilly Award, one of the earliest award, to the famous Banting Award in 2008, and the Claude Bernard Award in 2007, 2008, and the Ham International Prize, and more than 800 articles published in peer-reviewed medical journals. Dear friends, I'm presenting to you a very distinguished clinician, a great distinguished teacher, an absolutely fabulous investigator. Dear friends, long after, people would remember there was a man in our times called Dr. Ralph Anthony DeFranjo, who gave us the core science behind type 2 diabetes pathogenesis and how to address it. Dear friends, he's going to tell us today, as I told in the beginning, how do we strengthen our organoprotective therapies in type 2 diabetes mellitus. Ralph, all is yours. We're very eager to listen to you.
Good evening and welcome to tonight's program titled Strengthening Diabetes Management with Organoprotective Therapies. You've heard two excellent presentations and we now are going to look at two drugs specifically. We're going to look at a thiazolidinedione, pioglitazone, and we're going to look at a GLP-1 receptor agonist, liraglutide, and see how they fit into our approach for the treatment of people with type 2 diabetes. For those of you who know my background, I've always been a big advocate of understanding the pathophysiology of a disease, because if you understand what causes a disease, you'll understand better how to approach the treatment of the disease. So in 1987, I gave the Lilly lecture, and I titled it simply The Triumvirate. We knew that there were three core defects that are present in people with type 2 diabetes. There's insulin resistance in the liver, insulin resistance in the muscle, and beta cell failure. So in the diabetic patient, when the diabetic individual goes to sleep, their liver overproduces glucose, and this is the primary cause of fasting hyperglycemia. This is due to insulin resistance in the liver. The diabetic then wakes up in the morning. They may start with an elevated fasting glucose concentration. They ingest their meal, and what happens is there's a marked increase in the post-meal or postprandial glucose excursion, and this is due to insulin resistance in the muscle. And these two core defects in terms of insulin resistance are exacerbated by the progressive beta cell failure that characterizes our patients with type 2 diabetes. But in 2008, when I gave the Banting lecture, I had recognized the pathophysiology of type 2 diabetes was much, much more complex. And I titled it From the Triumvirate to the Ominous Octet, a new paradigm for the treatment of type 2 diabetes. So the three core defects are still present: insulin resistance in the liver, insulin resistance in the muscle, and beta cell failure. But now we need to add at least 5 other pathophysiologic disturbances. So let's focus here in the upper right, the fat cell. Initially, the fat cell is your friend. You overeat and you store those excess calories in the fat cell. However, if you continue to overeat and the fat cell expands, the fat cell becomes very, very resistant to insulin. And it starts to break down the triglycerides, and into the bloodstream, it releases free fatty acids. Elevated FFA impair insulin secretion, cause insulin resistance in the liver, and cause insulin resistance in muscle. We also know that the gut plays a major role in the pathophysiology of type 2 diabetes. And when we eat a meal, we release 2 incretin hormones, GLP-1 and GIP. And these 2 incretin hormones are responsible for about 70% of the insulin that's secreted in response to the meal. What we've learned that the amount of GLP-1 and GIP that's secreted by the K and the L cells in the gut is normal. The problem is that there's severe resistance at the level of the beta cell to the GLP-1 and the GIP that's released. We also know from studies carried out many, many years ago by Dr. Roger Unger and his colleagues that the alpha cell hypersecretes glucagon. And that hypersecretion of glucagon leads to an increase in hepatic glucose production. And this exacerbates this excess glucose production by the liver throughout the sleeping hours, exacerbating the rise in fasting glucose concentration. Studies that we did many years ago also demonstrated that the kidney plays a very important role in the pathophysiology of the disease. So in you or I, when our blood glucose level goes up and it reaches 180, that's the threshold for spilling glucose into the urine. And if the glucose goes above 180, all of the glucose that filtered above that gets dumped in the urine. But in the diabetic, that threshold is markedly increased, and it can go up to 240, 250, 60 milligram per deciliter. So instead of dumping the glucose into the urine, the diabetic kidney holds on to the glucose. And we also know that the brain has become involved now in the pathophysiology of the disease, but in a very different way. So we know that there are very important appetite regulating centers in the brain that tell us that it's time to stop eating. It turns out that these appetite regulating areas have become dysfunctional. And we know in particular that the GLP-1 that's released from the gastrointestinal cells, which sends a signal to the brain to stop eating. The brain has become very resistant to GLP-1. This leads to weight gain, and as we gain weight, we exacerbate the insulin resistance in the liver and in the muscle, and this increase in insulin resistance places the stress on the beta cell and leads to a progressive demise in beta cell function. So it should be very clear then, if we now need to talk about the treatment of type 2 diabetes, we're going to require multiple drugs in combination to correct these multiple pathophysiologic defects. No single drug is going to be able to correct all of these 8 disturbances. We also should recognize that when we're choosing drugs, we should pick drugs because they do correct the underlying etiologic defects that are present in people with type 2 diabetes. We shouldn't be picking drugs simply because they lower the A1C, because on a long-term basis, we're not going to maintain that reduction in A1C. And then thirdly, we need to start early in the natural history of the disease if we're going to prevent the progressive beta cell failure that is characteristic of type 2 diabetes. And what's worse is that we know with time there's loss of beta cells. And once we lose beta cells, that's going to relegate us to insulin therapy. So if we're going to be successful in treating our diabetics, we need multiple drugs that correct the underlying pathophysiology, and we need to start early. Now, I'm going to take you back to the United Kingdom prospective diabetes study to show you, number one, the importance of good glycemic control, which was the primary purpose of the UK PDS, but also to, I hope, clearly convince you that we need to start early, but we need to start early with the right drugs. So Dr. Robert Turner, many, many years ago in the late 1980s, carried out a classic, a landmark study that was the first study in type 2 diabetic patients to demonstrate that good glycemic control really did decrease the microvascular complications. Now, Dr. Turner believed that if you took newly diagnosed type 2 diabetic patients with a starting hemoglobin A1C and you placed them on a single oral agent, and the 2 oral agents that were available now at this time in the United Kingdom were metformin and a sulfonylurea glibenclamide or glyburide, that the A1C would come down and it would stay down for the duration of the diabetic patient's life. So in this study, there were over 4,000 individuals. 1/3 of the people got placed on conventional therapy. This was diet and exercise in yellow. And you can see there was a progressive rise in the A1C. And what he showed is this was all due to progressive beta cell failure. When he put the people on glibenclamide, the sulfonylurea binds to the sulfonylurea receptor in the beta cell, kicks out insulin. The hyperinsulinemia overcomes the insulin resistance. In the first year, the A1C drops. But you can see on a long-term basis, the sulfonylureas do not maintain the reduction in A1C, and there's a progressive rise in A1C. Now, what about metformin? Most of you think metformin is an insulin sensitizing drug, but unfortunately, that is a misconception. So I brought metformin to the United States in 1995. I did all of the studies that got it approved by the FDA, and using the gold standard insulin clamp technique, we clearly showed that metformin was not an insulin sensitizer. Metformin works on the liver to shut down hepatic glucose production. Fasting glucose and A1C come down, but because it has no insulin sensitizing effect and no effect on the beta cell, there's a progressive rise in the A1C. Now, as I pointed out to you, this was the first study that showed that this 1% difference in A1C between the conventional and the 2 treatment groups decreased eye, kidney, and nerve complications by 37%. So this is why this is a landmark study. But this also told us what drugs were going to work and what drugs were not going to work, because Dr. Turner clearly showed that glibenclamide alone and metformin alone were not going to drop the A1C and keep it down. Now, 5 years into UK PDS, Dr. Turner noted that the A1C had risen back to baseline. And so he wrote 5 papers, BMJ, Lancet, Diabetes Care, Diabetes, and Diabetologia. And he said, my hypothesis is not correct. You cannot put people on a single oral agent, drop the A1C, and keep it down. So he said, if you're on metformin, I add glibenclamide. If you're on glibenclamide, I add metformin. And if necessary, I'll add insulin. So now 15 years later, everybody is on a sulfonylurea metformin. 65% of the people are on insulin. And if you read across, the A1C is 8.6%. So this is the standard therapy that's used in the United States and in most people throughout the world. We start with metformin, and when you fail, we add sulfonylurea, and then when you fail, we add insulin. This treat to fail approach clearly ends up with failure. Now, let's take a look at the thiazolidinedione class of drugs. We've had two of them, pioglitazone, rosiglitazone. In the United States, rosiglitazone no longer is available. We have only pioglitazone. But you can see here with the TZDs a very, very different picture than what we saw with sulfonylureas and metformin. The initial drop in A1C differs in these 8 studies because the study designs are very different. But whatever that initial drop in A1C is, you can see that the A1C stays down, and it stays down for upwards of 6 years, as was shown in the ADOPT study by Dr. Stephen Kahn. Now, if the A1C declines and it stays down, this can only happen if the drug has a major effect to preserve beta cell function. Now, I think everybody who's listening to this presentation knows that the TZDs are powerful insulin sensitizing drugs. And over the years, we've used the insulin clamp to measure insulin-mediated glucose disposal before and after treatment with pioglitazone or rosiglitazone. And you can see if we look at the rates of glucose metabolism in response to a physiologic increase in insulin, there's about a 35 to 40% improvement in insulin sensitivity. Now, that is not the major reason why the A1C stays down on a long-term basis. It was very clear to us that the thiazolidinedione class of drugs must also have a powerful effect on the beta cell to augment insulin secretion. So this is the gold standard on the y-axis for beta cell function. This is called the disposition index. We do an OGTT and we look at the insulin secretory rate, and we factor the increase in insulin secretory rate by the increase in glucose during the OGTT. But in addition, we need to take into account the severity of the insulin resistance. And during the euglycemic insulin clamp, we have a measure of insulin resistance. And so now we can calculate, as I said, the disposition index, which is the gold standard for beta cell function. So if we take drug-naive patients and we put them on placebo, no improvement, of course, not surprising, in beta cell function. If we take drug-naive patients and we put them on pioglitazone, we get a tripling of beta cell function, insulin secretion, the disposition index. And you see a very similar effect with rosiglitazone. So if we now come back to our ominous octet, we see that the thiazolidinediones and pioglitazone in particular are powerful insulin sensitizers at the level of the liver, lower left. They're powerful insulin sensitizers in the muscle, lower right. They're powerful insulin sensitizers on the fat cell, upper right. And they are excellent drugs in improving and maintaining the improvement in beta cell function. So these drugs, pioglitazone in particular, that we're going to be focusing on tonight, correct 4 of the major pathophysiologic disturbances that are present in our type 2 diabetic patients, and therefore they're going to be excellent drugs for treating our diabetic patients. And I use pioglitazone in all of my patients as first-line therapy, but in combination with a GLP-1 receptor agonist, which we'll come back to later in the presentation. Now, what about pioglitazone in cardiovascular events? Well, we actually have a very, very good study called the PROACTIVE study, which was carried out many years ago in Europe, where they looked at 5,238 type 2 diabetic patients who had had a previous cardiovascular event, and they wanted to know whether pioglitazone could reduce recurrent cardiovascular events and mortality. And you can see here in the left, the placebo in yellow and the pioglitazone curve in orange, with the pioglitazone curve falling below the pioglitazone. So this is a Kaplan-Meier plot of time to death, myocardial infarction, and stroke. This is the MACE endpoint, and this is what's required to get drugs approved in the United States for cardiovascular protection. You can see hazard ratio 0.84. There was a 16% decrease in cardiovascular events. But unfortunately, in the proactive study, the primary endpoint was MACE plus leg revascularization, and we know that leg revascularization really doesn't respond to any kind of therapies, very refractory. And because of that, the primary endpoint, which is MACE plus leg revascularization, did not quite reach statistical significance, even though the MACE endpoint itself was highly statistically significant. Now, while these studies were being carried out in Europe, in the United States, Takeda Pharmaceuticals was carrying out a number of studies to get pioglitazone approved by the FDA. And this is now a meta-analysis by the Food and Drug Administration. This slide here to the right is taken by the FDA website. And so these are all of the studies that Takeda Pharmaceuticals carried out in the US to get the drug approved for treatment of diabetic patients. And get into these studies, you could not have a previous cardiovascular event. The hazard ratio here is 0.75, a 25% decrease in cardiovascular events. And this represents primary prevention because, as I pointed out, to get into these studies, you could not have a previous cardiovascular event. Now, in the proactive study, if you were treated with pioglitazone, recurrent stroke was decreased by 47%. So a good colleague of mine, Drs. Kernan and Silvio Enzucci at Yale, were aware of the proactive study, and they undertook a study in almost 4,000 non-diabetic subjects. I want to emphasize this. Non-diabetic subjects who had a recent TIA or a stroke within the last 6 months. And these people were then relegated to therapy with pioglitazone or placebo. Now, I want to emphasize that in this group of people, the hemoglobin A1C was 5.8. So what this means then is half of the people were pre-diabetics, the cut point being 5.7. The other half of the people had normal glucose tolerance. But none of these people had type 2 diabetes. They were treated with pioglitazone and followed up for approximately 5 years. And the primary endpoint was recurrent stroke or myocardial infarction. And here you see that the pioglitazone curve in orange falls above the placebo curve. And we're looking at the cumulative probability of event-free survival on the y-axis. Hazard ratio 0.76. So in this study, in non-diabetics, half pre-diabetes, half with normal glucose tolerance, there was a 24% reduction in recurrent cardiovascular events for with pioglitazone. So pioglitazone was a very, very potent drug in preventing recurrent atherosclerotic cardiovascular complications. So how does pioglitazone do this? It's a PPAR gamma activator, and PPAR gamma activation directly inhibits the atherosclerotic process. Pioglitazone improves insulin resistance, and multiple components of the insulin resistance syndrome were intimately associated with the atherosclerotic process. Pioglitazone improves endothelial dysfunction by stimulating nitric oxide, which was one of the most potent vasodilators and anti-atherogenic molecules in the human body. Pioglitazone inhibits inflammation, and we see that very easily by a decrease in the CRP. Pioglitazone reverses lipotoxicity by mobilizing fat out of the arterial tree. It decreases plasminogen activator inhibitor 1. It is very good at dropping the blood pressure, and it corrects diabetic dyslipidemia. And it's this constellation of multi-atherogenic factors that are reversed by which pioglitazone exerts its salutary effect on the atherosclerotic process. We also know that TZDs are very good at preventing the progression of prediabetes to diabetes. There have been a number of studies that have been carried out, starting with troglitazone and rosiglitazone and pioglitazone, and we were involved in one of the very early studies called ACTNOW, which stands for Actos Now for the Prevention of Type 2 Diabetes. We screened 1,850 people to find 602 individuals with impaired glucose tolerance or prediabetes, and they were randomized to either placebo or pioglitazone, and then we followed them up for a period of some 50 months. And you can see here that the conversion rate of prediabetes to diabetes was 7.6% in the group treated with placebo versus 2.1% per year in the group treated with pioglitazone. Hazard ratio 0.28, a 72% reduction in the conversion rate of prediabetes to diabetes, a truly astounding observation. Number needed to treat. We need to treat 18 subjects for 1 year to prevent the development of 1 case of type 2 diabetes. A very, very, very cost beneficial therapy. Now, to put this into perspective, if you've had a myocardial infarction and I put you on a statin, the number to treat to decrease recurrent myocardial infarction is about 20 to 25. So we don't want our people with diabetes having recurrent myocardial infarctions, and we also don't want people progressing from prediabetes to diabetes, and pioglitazone is as effective in preventing the progression of diabetes as a statin is in preventing a recurrent myocardial infarction. We also carried out studies to show that thiazolidinediones are very effective in preventing the progression of NASH. So this actually was the very, very first study with a drug, and in this study we used pioglitazone that showed that it could decrease the progression of NASH. This was published in the New England Journal of Medicine in 2006. In the original publication, there were 55 people. We subsequently expanded this to over 150 who received a biopsy and then were treated with pioglitazone and then had a recurrent biopsy. These people were also placed on a diet, moderate caloric restriction, 500 calories, then randomized to either placebo with the diet or pioglitazone with the diet, and they were followed up for 24 weeks. If we look at the liver function test, AST to the left, ALT to the right, you can see in orange a dramatic reduction in normalization of both the AST and the ALT. And there was some benefit in the placebo group, primarily because they were placed on a diet and they did lose a little bit of weight. But you can see the drop in AST and ALT were not nearly as good as in the pioglitazone group. Now let's look at the components of the NASH syndrome. A significant decrease in inflammation, significant decrease in ballooning necrosis, marked reduction in the amount of fat in the liver, and borderline reduction in fibrosis. When we followed these people up for a year and a half, the decrease in fibrosis became statistically significant, and the benefits in terms of inflammation, ballooning necrosis, and steatosis persisted. Now, there are some issues that have come up with pioglitazone. I've listed these as side effects, but in my opinion, they're not really side effects. They're misconceptions that are present and unfortunately have inhibited the use of this drug. We're going to talk about weight gain, this concern about bladder cancer, fluid retention, and bone fractures. Let's start with weight gain. I think everybody who's listening in knows that if you put people on TZDs, they tend to gain weight. Now, if we look at people with type 2 diabetes, in their bloodstream, they have elevated FFA. We've already talked about the fact that elevated FFA cause insulin resistance and impaired beta cell function. They have too much fat in the muscle, too much fat in the liver, too much fat in the visceral and subcutaneous area, too much fat in their arteries, and too much fat in the pancreas, impairing beta cell function. Now, when I put you on a TZD, what I'm going to do is I'm going to shift the fat around. I'm going to mobilize the fat out of the muscle, out of the liver, out of the visceral area, and out of the arteries, and I'm going to shift it to the subcutaneous fat. Now, while the fat is in the subcutaneous fat, it's in a certain way inert. It cannot hurt you. Now, if I simply shift the fat around, this doesn't promote weight gain. So why you gain weight? Because the richest density of PPAR gamma receptors are in the hypothalamus, in the appetite regulating centers. And when you activate PPAR gamma, this causes you to overeat. You get hungry and you gain weight. But that excess calories are placed here in the subcutaneous area where it can't hurt you. So it turns out there's a very strong correlation between weight gain and all the beneficial effects. So the more weight you gain, the better the improvement in hepatic insulin sensitivity, the better the improvement in NASH. The more weight you gain, the greater the improvement in insulin sensitivity. The better, more weight you gain, the better the improvement in beta cell function. The more weight you gain, the greater the drop in blood pressure, and the better the improvement in the dyslipidemia that's present in our diabetic patients. This is somewhat difficult to understand because most of us think that weight gain, and it's true if you overeat and gain weight, is associated with a lot of negative things in our diabetic patients. But because the weight gain is depositing all of the fat in the subcutaneous area, and because we're shifting fat out of all of these organs, the weight gain correlates with the beneficial effects. Now, let's come back to the proactive study. There was only one factor that predicted that participants would not die. So what is that factor? I love to give this talk to cardiologists and to endocrinologists because they don't know the answer to this. So what is the one factor? The one factor is weight gain, okay? So the more weight you gain, the less likely you are to die. So you have a choice. You can either be lean and dead, or you can be a little bit fat and alive. You pick, okay? So let's look at this issue about bladder cancer. The Food and Drug Administration required Takeda Pharmaceuticals to do a long-term study to look and see prospectively whether pioglitazone, in fact, did promote bladder cancer. This study was carried out in Kaiser Permanente, Northern California. There are 193 type 2 diabetic patients. And during this follow-up period, 1,089 developed bladder cancer. You can see 137 were treated with pioglitazone, 952 never received pioglitazone. So what was the hazard ratio for development of bladder cancer? 0.98. Remember, a hazard ratio of 1 means the drug has no either deleterious or beneficial effect. So it is very clear that pioglitazone does not promote bladder cancer. And this is another misconception that's present in the literature. Now, what about fluid retention? Why do people treated with pioglitazone retain fluid? Does it have anything to do with the heart? So this is a study which we carried out, and you can see it's published in Diabetes Care some 6 years ago. But interestingly, few people actually ever read the study or are aware of it. So in this study, we took people with type 2 diabetes and we treated them with pioglitazone. And you can see in yellow is pre-pioglitazone, in orange is post-pioglitazone. A nice drop of 1.1% in the hemoglobin A1C. Now, what about insulin sensitivity with the insulin clamp and skeletal muscle? A major, almost doubling of skeletal muscle insulin sensitivity. We also carried out the study with fluorodeoxyglucose in PET to look at myocardial insulin sensitivity. You see a doubling of myocardial insulin sensitivity. And if we look in myocardial blood flow with pioglitazone, a dramatic improvement in myocardial blood flow. Let's now look at LV systolic function. Here's the ejection fraction. Went up by 5%, okay? If we look now at measures of diastolic dysfunction, the transmitral E over A ratio, huge increase. End diastolic volume, big increase. In peak left ventricular flow rate, all three of these measures of diastolic dysfunction markedly improved. So what is pioglitazone doing to the heart? Only good things. So why do we retain fluid when we treat people with pioglitazone? So pioglitazone, as I pointed out to you, releases nitric oxide. Nitric oxide is a powerful vasodilator. This drops the blood pressure. This leads to a decrease in renal perfusion. And anytime there's a decrease in renal perfusion, there's a signal to the kidney to hang on to salt in water. So yes, there is fluid retention, but it has to do with the vasodilatory effect of pioglitazone, not to its negative effect on the myocardium. So at this part of the presentation, what can we summarize about pioglitazone? It causes a durable reduction in the A1C for upwards of 5 years because it improves insulin sensitivity and, equally important, maybe more importantly, preserves beta cell function. At the molecular level, it enhances the insulin signal transduction system. This is why we see an improvement in insulin sensitivity. And it inhibits multiple inflammatory and atherosclerotic pathways, giving us this benefit in terms of prevention of atherosclerotic cardiovascular events. It reverses lipotoxicity, mobilizes fat out of all tissues in the body and deposits it in the subcutaneous area. It improves diabetic dyslipidemia. And as I said, it decreases cardiovascular events and is very, very effective in preventing hepatic steatosis and fibrosis. Let's now take a look at the second class of drugs that I want to talk about tonight, and that's the incretins. So in response to an oral glucose load, we always release much, much more insulin than if we give the glucose intravenously. And this is called the incretin effect. And there are two incretins that are involved here. One is glucagon-like peptide 1, GLP-1. The second one is GIP, difficult to pronounce, glucose-dependent insulinotropic polypeptide. These two incretin hormones account for 60 to 70% of the insulin which you secrete in response to a meal. So obviously they're very, very critical hormones in the regulation of glucose homeostasis. Now, there are a number of GLP-1 receptor analogs that are approved. The first one was exenatide, and I had the good fortune of directing the exenatide studies. This is by Ada, which was given BID. We no longer use this. We're going to talk a little bit tonight about liraglutide, once daily, Victoza. We now have drugs that are given once weekly. We have Bidurion, dulaglutide, Trulicity, semaglutide, and most recently, the new kid on the block, tirzepatide or Mounjaro. So what do we know about the GLP-1 receptor agonists? They are excellent drugs in reducing and maintaining the reduction in A1C because they have a powerful effect to increase insulin secretion and maintain the improvement in beta cell function. They inhibit glucagon. They promote weight loss. As I'll show you in a moment, they correct 6 of the pathophysiologic defects in people with type 2 diabetes. They do not cause hypoglycemia, so they're very safe, and they can be used with pioglitazone, which also does not cause hypoglycemia. Other than nausea and in a small percentage of people, some vomiting when you start the drug, they have an excellent safety profile. These GI side effects usually dissipate over the first 2 to 4 weeks of therapy, and they also reduce cardiovascular events. Now, I'm going to show you only a couple of studies. This is a study that Dr. Davies and I carried out. This is part of the SCALE program, where we looked at the effect of liraglutide on glycemic control to the left, insulin resistance, HOMA-IR in the middle panel, and beta cell function, HOMA-beta to the right. And we looked at 2 doses of liraglutide, a 3 milligram and a 1.8 milligram dose. And you can see to the left, nice drops in A1C, about 1.2 to 1.3. Placebo really in this study had very little effect on the A1C. HOMA-IR, particularly at the higher dose of liraglutide, which is associated with more weight loss. I'll show you the weight loss in a second. We see an improvement in HOMA-IR. There are no GLP-1 receptors in muscle, so this improvement in insulin sensitivity is due to the weight loss. And to the right, you see the outstanding effect of liraglutide to improve HOMA-beta. So we're seeing very nice insulin sensitizing effects, very nice effects on the beta cell, leading to a very nice drop in A1C. Now, here in the same study that I showed you in the previous slide are the effects on body weight. There was a modest reduction in weight loss in the placebo-treated group, but you can see at the high dose of liraglutide, we have about a 7 kilogram drop in body weight, or about 16 to 17 pounds. And it's this decrease in body weight which is leading to the improvement in insulin sensitivity. So if we come back now to our ominous octet, the GLP-1 receptor agonist, liraglutide, by giving a pharmacologic dose, overcomes the defect at the level of the beta cell, increases insulin secretion, also inhibits glucagon secretion. The increase in insulin and decreasing glucagon shuts down hepatic glucose production. GLP-1, now because we're giving it in a pharmacologic dose, shuts off your appetite, you lose weight, you get an improvement in insulin sensitivity. So we're correcting 6 of the defects that are present in the ominous octet. Now, what about cardiovascular benefit? So I'm going to read from left to right. This is the leader study with liraglutide. Next one is SUSTAIN 6 study with semaglutide, the EXCEL study with exenatide, and then the REWIND study with dulaglutide, all showing significant cardiovascular protection in high-risk groups of individuals with a previous cardiovascular event or high risk factors, hazard ratio 0.87, 0.74, 0.91, 0.88. So GLP-1 receptor agonists also have, in addition to their effects to improve glycemic control, very good effects to decrease recurrent cardiovascular events. There's also some suggestion that these drugs, and these are data with liraglutide that I'm going to show you, may slow the progression of diabetic kidney disease. Again, this is from the SCALE study. There's a composite renal outcome. Here is the hazard ratio, 0.78, which is significantly decreased. Now, if we look at the individual composite components, macroalbuminuria was significantly decreased, and this is what's primarily driving the hazard ratio. There was also, if we look at doubling of the serum creatinine, hazard ratio 0.89, in renal replacement therapy, hazard ratio 0.87, did not quite reach statistical significance, but were trending in the right direction. There are larger studies that are going on now with the GLP-1 receptor agonist to examine whether these more definitive endpoints, including renal replacement therapy, will be benefiting. So in conclusion, combination therapy with pioglitazone and a GLP-1 receptor agonist can be expected to provide additive effects on glycemic control, insulin resistance, beta cell function, lipotoxicity, prevention of NAFLD and NASH, cardiovascular protection, and maybe also renal protection. So I like this combination, and although I'm not going to speak about the SGLT2 inhibitors, I like the SGLT2 inhibitors as the third drug, as my triple therapy combination. So I'd like to thank all of you for listening on, and we'll now have time for an extensive question and answer period from all of our sites that are listening in. Again, thank you very much for your attention.
Thank you, Professor DiFrangio, for a very epoch-making talk and giving what I call practice pearls of how to use a combined therapy of pioglitazone plus GLP-1RA. And also you're given the direction how this combination can produce immense benefit, not only the glycemic control, but the cardiovascular benefit and maybe renal benefit. And how will it work for protecting the organs? Dear friends, I must mention here before the panel discussion starts that Glenmark is on the verge of introducing the biosimilar version of the GLP-1RA. And I have a feeling that with the introduction of that, the drug will become affordable and will be available and accessible. But what Professor DiFrangio has clearly shown that it is the most appropriate drug to be used. That was the beauty of your talk, sir. And you clearly showed the immense benefit. I mean, you highlight the four areas where the pioglitazone works and how the 4 areas it scales upon. You talked about the new molecule of the GLP-1RA. And of course, I personally feel it will come in the question answer session. The SGLT2 is good, it's oral, but the benefits are not comparable. GLP-1RA, to my mind, in certain areas, it had also rub off in producing these benefits. We're also aware of your combination therapy of GLP-1RA, pioglitazone, and SGLT inhibitor, and metformin, and producing a great change in the destiny of the diabetic persons in your country, and many are adopting that today. With this much a remark, it's my great pleasure and honor to request all the panelists. Bipin is here, JB is here, and of course, Professor DiFrangio is here, and we'll have question answer session. May I now request Abhishek to kindly announce the panel discussion, and we'll take it forward. Abhishek, Dr. Abhishek Mane.
Yes, sir. Thank you so much, sir, for that wonderful speech. Thank you to all the speakers.
I must tell you, DiFrangio, it was an epoch-making talk.
Yes, sir. Definitely. Truly forward looking to it, sir.
Yes.
So, sir, as we have now panel discussion agenda, so we have all the dignitaries up on the floor, and now we would like to go one by one to all our physical centers, pan India. So, sir, starting with the panel discussion, first we'll move on to our Delhi center, where we have Dr. Sunil Kohli, sir, as our moderator. And we would like to hear from you, Dr. Sunil Kohli, sir. What are the thoughts from the delegates, and what are the questions?
Thank you so much. I think we've all listened with great interest to the discussions on GLP-1 receptor agonist, the combination of a DPP-4 and pioglitazone, and also Professor DiFrangio's talk on liraglutide as well as pioglitazone. The question that arises in our mind is that, across all trials, the dosage used has been 15, 30, or 45 milligrams that you mentioned. What would be the optimal dose for our Indian patients? And the second part, that doubt always remains. You did mention the case of permanente study, which said that there is no indication of bladder cancer. But
yes.
That said, the warning remains on pioglitazone with the US FDA on the increased odds of bladder cancer with long-term use and with a higher dose use. So what would be the optimal dose of pioglitazone? That's for Professor DiFrangio and all the panelists, if they would like to answer.
I think it's a great question. I'll request Dr. DiFrangio to kindly answer.
Yeah. So in general, when we carry out the studies, we're investing a lot of money, time, and effort. So we've gone to the 45 milligram dose. But in my practice, I rarely go above 30 milligrams. We actually looked at the dose response curve, and this article is published in Diabetes Care in year 2000. And you start to get a glucose lowering and insulin sensitizing effect at 7.5 milligrams. At 15 milligrams, you have a very nice insulin sensitizing effect. and you start to see the beta cell effect. At 30 milligrams, you're getting almost all, let's say, 80 to 90% of the insulin sensitizing effect and a good beta cell effect. And if I'm going to go to the 45 milligram dose, I don't get too concerned about that because all of my patients are going to be concomitantly on a GLP-1 receptor agonist. Again, you are correct that the warning still remains in the package insert for bladder cancer, but I showed you the data that that the FDA mandated a study. Hazard ratio is 0.98. It seems a little bit strange to me that they mandated a study. They get the result of the study, which clearly shows that there's no increase in bladder cancer, and yet they keep the warning there. So I guess you'll have to explain. You'll have to talk to the FDA as to why they did remove the warning.
Professor Diffranjo, in India also we had set up a pharmacovigilance committee with two famous pharmacologists, Dr. Nilima Kirsagar and Urmila Thate, and it is now almost 3.5 years, 4 years over. We do not have any signal yet. Thank you.
Thank you for that comment.
Next center, because we'll come back to second round, subject to available time.
Exactly. So moving ahead with our panel discussion, the next center will be Kolkata. So from Kolkata, we have Dr. Salil Kumar Pal, sir. So welcome, sir. Yeah, please have your question.
Continuation with bladder cancer, is related to dose of pioglitazone or 40, that is the patients who had bladder cancer with pioglitazone, those patients were getting higher dose of pioglitazone? Is it so?
It was very difficult for me here to question.
Yes.
Is bladder cancer dose related?
Yeah, well, as I said, in the only prospective study carried out by the FDA, there was no increase in bladder cancer, and it didn't make any difference what dose you were on. Now, it's of interest to go back and look at why did this concern originally develop. So it turned out that in the initial rodent studies that were carried out by Takeda, that there was a significant increase in bladder cancer in female, but not in male rats. And what they noted, and in females, the bladder actually sits down quite low. And so the urine sits low, and there are crystals formed from the pioglitazone. And when, and as I said, you don't see this bladder cancer in the males. And then what they did is they alkalinized the urine. And when they alkalinized the urine, they completely got rid of any of the bladder cancer that they saw in the females. And this is what started this whole controversy. So I believe that what we saw is not going to happen in humans because it's a very different anatomy of the bladder, and we don't form these crystals in humans. So I understand that there is this concern that's out there, but as I've said, I've treated in my lifetime many, many hundreds of people with pioglitazone. I have never seen a case of bladder cancer, but there is a warning in the label. And when you're prescribing it with your patients, I think it is very important that you do discuss this with your patients and that you can, review with them the FDA mandated study and what the results were.
Thank you.
Thank you, sir.
Next center, Abhishek.
I'd be very interested to see what the other panel, Dr. Kamwar, Dr. Sethi, what's your feeling? Because you have a lot of experience with this in India.
Bipin, you can speak first. Very short answer.
Well, I think bladder cancer concerns are not there. The concerns are that of weight gain, heart failure, macular edema, bone issues of osteoporosis. And these are the issues with pioglitazone. I don't think we ever had issues, and Professor Das would remember when the ban was there in our country, it was not based on the bladder cancer. We believe that bladder cancer doesn't occur, but we know that this causes heart failure. And we know, and we remember the article written by Yaki Jarman, when she said that one has to balance between reducing atherosclerotic cardiovascular disease and heart failure. So it's a balance. I guess in the era that we live in, when we are trying to promote and use drugs that prevent heart failure, pioglitazone is a distant runner. I don't personally use it. But as I said, this is a buffet kind of a dinner, which four of us are not getting by the hour. You can pick and choose amongst many other drugs, and we already have metformin, we have got DP4 inhibitors, we have got SGLT inhibitors, and after that, Dr. Professor Das would remember the landmark study. After 3 drugs, it is almost important that we go to some injectable, maybe insulin or something. So I don't quite use pioglitazone. These are very personal opinion based on solid scientific data. Thank you.
Thank you. I think if you ask me, Professor, before I go to JB, that we have given the warning from the behalf of the government and the drug controller, and we haven't found any bladder cancer yet, as I told you. And the warning remains. And also we use a steep dose for the NASH, 30 milligram dose. What dose you recommend for the NASH? From the NAFLD, what dose you recommend for the pioglitazone?
Yeah, so we carried out the study and we went up to 45 milligrams, but there were a number of people who didn't get to the 45 milligram dose, and we saw the same benefit at 30 milligrams. And in the IRIS study, Dr. Zucchi and I, this was the cardiovascular study in people who had a previous TIA or stroke, and these data are published. It didn't make any difference whether you're on the 15, 30, or 45 milligram dose. We saw exactly the same benefit in all 3 of the groups. I do want to make a comment about what was just said about Hanali Yikiavanen analysis, and that every single thing that she said is 100% incorrect in the proactive study. I cannot let this statement go unopposed. If you look at the proactive study, there's a category of people who are listed as severe heart failure with edema. Now, if you have severe heart failure, the 1-year mortality is 30%, and the 5-year mortality is 80%. But if you look at the people who, quote, had severe heart failure with edema, they actually statistically lived longer than the people who were treated with placebo. So pioglitazone, despite the fact that it, quote, caused severe heart failure and edema, those people lived longer. So why was the reason for that? Because as I pointed out to you, and obviously at least one of the panelists has a major misconception about how pioglitazone works. It's a vasodilator, and all the fluid retention is due to underperfusion of the kidney. So these people were treated with diuretics, and after treatment with diuretics, in fact, now you see the beneficial effect, and the people live longer. So I suggest that you may want to go back and reread the article so that you see, in fact, what I'm telling you now is 100% correct.
Thank you. We'll go to Bangalore now.
That came as a editorial for the same study. And also the IRIS study and the NFL studies were sometimes done in the non-diabetic people. And in diabetic people, pioglitazone is not as yet approved. There is an elegant study, which prevents study wherein this pioglitazone was inferior to vitamin E. But that's a different issue altogether.
Yeah, I think we'll go to Bangalore Center now for interest of time.
Yes, sir. Sir, we are having Mumbai as the next center.
Mumbai. I'm sorry, Mumbai. Manoj
Yes,
first. Manoj.
Yes, sir. So, Dr. Manoj Chadha, please, sir, with your question.
Thank you. Dr. DiFronzo, I don't know if I missed out, but what is your thought on the position of metformin in our armamentarium as management of type 2 diabetes? Are you still using it as the first line drug, or you have second thoughts about it?
Well, I definitely don't use metformin as first line drug. That should be pretty obvious. I think there are major misconceptions about metformin. I like metformin. I brought it to the United States in 1995. It was a fantastic benefit because we had only sulfonylureas. At the present time, metformin is number 4 on my list of good drugs. I always start with triple therapy, and metformin is not part of the triple therapy. It is very, very clear. Metformin is not an insulin sensitizing drug. And anyone who says that, unfortunately, I guess they just really don't understand how metformin works. In order for metformin to get into cells, it gets in through the organic cation transporter. The organic cation transporter does not exist in muscle. It is impossible for metformin to get into muscle, and it does not get into muscle, and it is not an insulin sensitizer. And all of these data with the insulin clamp was submitted to the Food and Drug Administration in 1995. Now, the misconception that metformin is an insulin sensitizer has arisen from the fact that metformin can cause GI side effects. And in many of the published studies, there's weight loss that can be as much as 2 to 3 kilos. Now, if you lose weight on metformin, there's an improvement in insulin sensitivity. But in the absence of weight loss, metformin is definitely not an insulin sensitizing drug. And the only true insulin sensitizer is pioglitazone. It is very clear that studies that we've done, Jerry Schulman and many other people, that the major effect of metformin is on the liver, and in the liver, it inhibits gluconeogenesis, and in the liver, it is actually not even an insulin sensitizer. Its mechanism of action is related to an inhibition of gluconeogenesis. So I like it, I use it, it's very inexpensive, people can't afford the other drugs, I use it. Otherwise, I stay with the triple therapy of a GLP-1, pioglitazone, and SGLT2 inhibitor.
Good. We'll go to Bangalore now.
Yes,
I think the moderators have to answer the other questions in the group. Manoj, the moderators have to answer the other group. If time permits, we'll go for the second round.
Okay,
Yes,
we'll do
sure,
that.
sure, sir.
Paramesh?
Dr. Differenzo, thank you very much
So
for
now
the
we'll
excellent presentation. On behalf of all my colleagues from Bangalore, I would like to thank you for the excellent talk on the organoprotective benefits of these agents, of anti-diabetic agents. The question that Dr. Veda Prakash, my colleague here, and Dr. Dayanand has is about your thoughts on the use of pioglitazone in patients with ischemic heart disease and also in patients with cardiac failure.
Yeah, so in people with ischemic heart disease, I think the proactive study very clearly demonstrated a significant reduction in recurrent cardiovascular events in MACE. And unfortunately, as I pointed out, that was the second principal endpoint, and that's why it did not get approved by the FDA. There's also been a very large real-world study that I didn't review with you. And in that large real-world study, there was an even greater reduction in cardiovascular events. Now, in people with with heart failure with reduced ejection fraction, I don't use the drug. In people with heart failure with preserved ejection fraction, I personally think that pioglitazone will be the most effective drug for HFpEF. And we have a very large study that we're currently undertaking, in fact, to conclusively show that in HFpEF that this is likely to become the drug of choice. And as I pointed out to you, we already published the study in Diabetes Care that every single parameter of diastolic dysfunction, which is basically what HFpEF is improved with pioglitazone, and there was a 5% improvement in the ejection fraction. So again, it is very clear to me that people are not familiar with what's in the literature. They have misconceptions about what the drug does in the heart, whereas the data that are published clearly show that there's no deleterious effect on the heart. Nonetheless, I don't use it in people with heart failure with reduced ejection fraction.
Good. I think when you use along with GLP, I mean, what's the dose of pio that we use, Dr. Differenzo?
We go up to 30 milligrams in those studies.
Good. I think Abhishek, now over to Lucknow. Abhishek.
Yes, sir, yes. So now we'll have our next center for panel discussion. That is Lucknow. We have CG Agrawal, sir, joining us from Lucknow. Please, sir, your question.
Lucknow, sir, just unmute yourself, sir.
I think you're muted. CG, you're muted.
Lucknow, sir.
Sir, you're on mute. Still on mute, sir. Lucknow Center technical team, please.
Yes, sir. Yes, sir. Yeah.
Okay.
Now it's
Dr. Differenzo, once I heard you and you were advising us that the cause of edema in pioglitazone is something like amlodipine, and
Correct.
therefore
You are very observant.
can be used in type NHYAN 1 or 2, or even in higher grade of CHF. Now, in case of edema in a diabetic, where we are struggling with whether it is a renal edema or a cardiac edema, and there is proteinuria, what would be your advice for the use of pioglitazone?
Yeah. So first I want to comment, you're very smart. If pioglitazone, that drug was named amlodipine, we would use it in every patient with heart failure. And in fact, amlodipine, even though it causes edema, is recommended for treatment of heart failure and its cardioprotective effects. And amlodipine does exactly the same thing as does pioglitazone. And again, this misconception of equating edema with heart failure is just simply wrong. Now, in terms of, as I said, if you have, I am myself reluctant to use pioglitazone in people with heart failure and reduced ejection fraction. So when you have edema, I think you need to ask yourself, and this can easily be resolved by doing a cardiac echo. In the person who has edematous and you think may have actually intrinsic heart failure with a reduced ejection fraction, I would suggest that you get a cardiac echo. Personally, if the ejection fraction is 30, 35%, in that situation, I would not use the pioglitazone. I personally feel comfortable in using the drug in people with HEF, but my guess is you probably will not feel comfortable using it in that group of people. So that's a decision you'll have to make.
Thank you. We can go to now Guwahati. Manas.
Yes.
Thank you, sir. First of all, compliment to you for this insightful talk. Actually, it reminds me of the fight we had a decade back for in favor of pioglitazone. Professor Ashok Das was the leader. Actually, it was banned from the Indian market for a brief period of 2 weeks, and a lot of clinicians fought tooth and nail, and we won it back for the majority of Indian patients. And I can assure you, we have got probably millions of patient years experience now with pioglitazone, and India loves this molecule. But coming back to the question of using in heart failure preserved ejection fraction. So what about combining this molecule, I mean pioglitazone, with an SGLT2 compulsorily or like by default? Because in India, if we use it, suppose for a ejection fraction of 55% or so, we are not going to do echoes every now and then because we are not supported by any insurance package system. The patient have to pay from the upper care. Many times we are not able to ask for an echocardiography all the time during follow-up. So is it safer to combine this with an SGLT2 inhibitor? So because sometimes it's a continuous process, because some of the preserved ejection fraction heart failure may go into a reduced ejection fraction. So what about combining these two? Because both the molecules are pretty cheap, because Indians can afford it by and large, actually.
Yeah. So that's a very good comment. And that's an excellent combination of pioglitazone with SGLT2 inhibitor. And we actually have published that study combining SGLT2 inhibitor dapagliflozin with pioglitazone. That's a very effective combination in lowering the A1C in terms of promoting weight loss. And so I think you would also get an additive effect in terms of cardiovascular protection, although that cardiovascular outcome study with those two drugs combined, of course, has not been done. This is actually, I think, would be a very nice opportunity for you in India and maybe for Glenmark to actually look at that study. We've also published the combination of GLP-1 with pioglitazone, and that actually is also a blockbuster combination. And again, that's another study that would be, I think, of considerable interest for Glenmark to look at, particularly since they are interested in liraglutide and have pioglitazone. So I think that would be a great study for Glenmark to undertake in India.
Thank you.
Yes, sir. So, yes, sir. Can we just have JB Kanwar sir's and Vipin Sethi sir's perspective on this as well?
JB, you can speak your. That time.
Yeah, we do have very good data about SGLT2 inhibitor in HEPREF and HEP reduced ejection fraction. So along with when pioglitazone being used with HEPF, so that would be a very good combination to reduce the heart failure overall. So I would presume that these two combinations, as Dr. Difonso is saying, they already have work on that combination. That would be helpful for the patient with heart
failure. We can go to Chennai now. And Jayashree, if you can change the question to GLP-1 RA, if you like.
So you're having Nagpur as the second.
Oh yeah, Nagpur. Pramod is here. Pramod.
Yes, sir. Yes, sir. Yeah. So Dr. Pramod Gandhi, sir. Yes, sir.
Pramod, I'm sorry, I saw you in front of me.
No, it's okay, sir. Thank you. Thank you for that opportunity. Thanks, Dr. Difonso, for that wonderful deliberation. What I understood from today's discussion is you are suggesting metformin as possibly the fourth line of agent and probably glitazone, GLP-1 agonist and SGLT2 inhibitors as first three drugs. But if you see most of the guidelines, whether you talk about AAC, ADA, IDF, even our ESD and RSSDI Indian guidelines, most of these guidelines suggest glitazones as fourth or fifth line of agent and probably GLP-1 receptor agonist and SGLT2 inhibitors as second and third line of agent after metformin. So your comments on this?
Yeah, I mean, the guidelines are just wrong. It's very simple.
Guidelines, yeah.
Yeah. So I think in terms of the guidelines, it's very clear now that both the ADA and ESD have changed. So if you have heart disease, they recommend the first line drug on board should be a GLP-1 receptor agonist or an SGLT2 inhibitor. If you have heart failure, the first drug on board, the guidelines say, should be an SGLT2 inhibitor. If you have renal disease, first drug on board should be an SGLT2 inhibitor. So these guidelines now are changed for the year 2023. The problem is only 15 to 20% of our patients have established heart failure or renal disease. So what do we do in the other 80%? In there, the guidelines basically say that you can use anything. First column is sulfonylureas. They have DPP-4 inhibitors. They have pioglitazone. They have the GLP-1 receptor agonist and insulin. And I personally do not agree with those guidelines. And in fact, if you look at the GRADE study, which was just published several months ago in the New England Journal of Medicine, they conclusively show that not all drugs are created equal. So to get into the GRADE study, you had to have an A1C above 7.5. You have to have failed on metformin. So first point is in 5,000 people, they're telling you that metformin has failed, okay? So it's first-line therapy, we know it's failed. So to get into GRADE, you had to have an A1C 7.5 or above on metformin. And then what happened? When you add sulfonylureas, a good benefit in the first year, just like UK-PDS, fail thereafter. What about DPP-4 inhibitor? Good response in the first year, fail thereafter. So I personally do not agree with the ADA guidelines in the 80% of people who do not have established cardiovascular or renal disease. And in fact, I think it's very clear from our EDIC study, the best way is to go in newly diagnosed patients is with triple therapy, and in people with long-standing diabetes, even with very elevated A1Cs. The Qatar study that Dr. Abdulghani and I published also clearly showed that addition of pioglitazone, we used exenatide in that study, is much, much more effective even than a mixed split insulin regimen. And those two studies are both published in Diabetes Care.
We'll come to Chennai now, Abhishek.
Yes. So the next center for discussion is Chennai. We have Dr. Jayashree Gopal, madam, from Chennai. Over to you, ma'am.
Good evening, Dr. Difonso. Again, a very, very thought-provoking lecture. A couple of questions here. both from me personally and from the people who were gathered here. One is regarding macular edema.
Yeah.
So I would assume that, and just for the benefit of all the practicing clinicians, quite often in our country, a lot of the diabetic patients do not get their annual eye checkups done. So I would assume that they would need to get an eye checkup and macular edema be excluded before they get started on pioglitazone. Is that a complete contraindication? What if it's treated? And sorry, the second also is,
but let me just handle one question at a time. Can I just handle one question at a time?
Sure,
so let
sure.
me
Go ahead. Sorry.
First, there are isolated case reports of macular edema in people with both pioglitazone and rosiglitazone. These are incredibly, incredibly, incredibly rare. Now, that's number one. Number two, all people, these are standard guidelines throughout the world, should have, at the time of diagnosis of type 2 diabetes, they should have an eye exam. That's standard of care. And anybody who has proliferative retinopathy or macular edema should be referred to an ophthalmologist for appropriate evaluation. So I don't think it's wise to be starting any drugs in any patient without an eye exam. And one could raise the same issue about GLP-1 receptor agonist. If you have macular edema or proliferative retinopathy, it needs to be treated appropriately, and then you will decide in consultation with the ophthalmologist as to whether or not pioglitazone, GLP-1 receptor agonists are indicated in that particular individual patient. Question number two.
Question number two, similar scenario, but someone who presents with having had a fracture.
Yeah. So in my opinion, the major contraindication to using pioglitazone, and probably the only one, is the bone issue. So it is true that a very small percentage of people, 1 to 1.5% of people who are placed on pioglitazone long-standing will experience a bone fracture in the distal bones, usually related to trauma, falling, and usually in the arms. These fractures are primarily observed in postmenopausal females. They're not observed in males. So in postmenopausal females, recommendations are that all such women should have a bone mineral density. That's part of normal health evaluation. If they have a decrease in bone mineral density, I would not use the pioglitazone. If they have normal bone mineral density, I feel comfortable with using the pioglitazone. You still may not feel comfortable in that group. That would be a decision that's up to you to make. But in premenopausal females and in males, this, in my opinion, is not a significant concern.
Thank you.
And go to next
sentence. So can we have Dr. Bipin Sethi sir's view on this as well?
I think Professor Das wanted some discussion on GLP-1 analogs as well.
Yeah,
we have had enough and more of this. Since you asked me, I also said that this is a buffet kind of approach. You can choose drugs which you are comfortable with, which you are having in your practice. There are reasons to believe that some drugs are better than others. But at this moment, I would agree with Professor DiFranzo that we should try to achieve targets with drugs that do not cause hypoglycemia, so we can achieve good targets and prevent complications. The choice of agents, of course, is purely personal.
Yeah. Okay, thanks. So we'll move on to our next center, that is Jaipur. Dr. Shailesh Lodha, please, sir, with your question.
Shailesh, if you have any question on GLP-1, I'll take up that, if you have.
Dr. Raj, the problem here is regarding the dosage. Majority of our patients don't tolerate 1.3 milligram of linaclotide. Similarly, 30 to 45 milligrams of pioglitazone not tolerated by majority of our patients. Most of the trials have the benefits in these dosage, either with 30 or 45 milligram of pioglitazone and 1.8 milligram of linaclotide. So in such situation, how do we deal?
It's about the dosing, Professor DiFranzo.
Yeah.
Professor Shailesh says that many people get the benefit only at the 1.8, not at 1.2 or 0.6. So they do not tolerate 1.8. Similarly, also the high dose of PIO, people may not tolerate. So let's have your comment on the effectivity of GLP-1 at 1.2.
Yeah. So we're talking about liraglutide specifically.
Yeah, exactly.
So the normal starting dose is 0.6. Then you go to 1.2, 1.8. For Saxenda, same drug, but treatment for obesity, it's a much higher dose. But if you start at the lower dose, 0.6, usually in my hands, this is pretty well tolerated. But if the person has continued nausea, then you should not titrate the drug up. You should still stay at the 0.6 dose. Usually after 4 to 6 weeks, they will tolerate the 0.6 dose, and then you'll can go to the 1.2 dose. And again, same approach. If the patient's experiencing nausea, you cannot titrate the drug up. You just have to stay for a longer period of time. And as you point out, but I have to say, this is relatively uncommon in my experience. There are some patients who you just can't get to the 1.8 milligram dose. And obviously, if they're having significant nausea, they're simply not going to be able to go to the higher dose. But you still see significant benefit in the published studies at the lower doses. So this is something you have to sort of individualize with that patient. Same thing with pioglitazone. Remember, I told you, and in fact, I see there's probably very little need to go to the 45 milligram dose. And in the cardiovascular outcome study in IRIS, I told you that Dr. Zucchi and I, we reanalyzed all the data. And you saw the same cardiovascular benefit at 15 and 30 as you saw with 45. So you can feel quite comfortable at the 30 milligram dose. In our hands, in the NASH and NAFL study that Dr. Kuzi and I published, we had a significant number of people who didn't get to the 45 milligram dose who were at 30 milligram, and they benefited as well. So I think 30 milligrams is a very good dose to strive for. And if I'm going to go to the 45, I don't get too worried about it because all of my people are also on a GLP-1 receptor agonist, which is going to blunt any of the weight gain. And again, that's mostly a cosmetic issue. It is not a metabolic issue. As I told you, the more weight you gain, every single parameter that you can look at gets better.
Yeah, I think coming back to the dosing of GLP-1 RA, I think me, Bipin and JB, all of us have seen Shailesh, not very high, but significant weight loss with 1.2. And we should not, sometimes people do not tolerate, don't go to 1.8, stay at 1.2. Correct. Next.
Agreed.
Yes. So we'll move on to our next center, that is Bhubaneswar. So we have Dr. J. Kishore, sir, joining us. Sir, please, your question.
That was a very enlightening talk. And while we talk about the organ protective approach of diabetes of management, a brief comment from Dr. DiFranzo on the renoprotective effects of pioglitazone in view of its antifibrotic properties.
Yeah. So a long time ago, I tried to convince Takeda Pharmaceuticals to actually do the renal protective effect. And I didn't feel that there was a financial market to do this study, so they didn't do it. But if you go to the animal data, there's an enormous literature, starting with troglitazone, also with rosiglitazone and pioglitazone, in every model of diabetic as well as models of non-diabetic nephropathy, that the TZDs are really quite quite renal protective. We actually published a study, it's in Diabetes Care, with rosiglitazone, and we looked at people with macroproteinuria. It was actually a quite large number of people. Half the people were placed on rosiglitazone, and the other half of the people were placed on metformin to decrease the hemoglobin A1C to the same level. What we saw is with metformin, no decrease in proteinuria. With rosiglitazone, a dramatic reduction in proteinuria. I personally believe that these drugs, the TZDs, do have renal protective effect, but there is no long-term study looking at the definitive endpoint, which would be change in glomerular filtration rate or progression to end-stage renal disease, meaning dialysis or transplantation. It's a study that I think should have been done. It's not been done. You know, whether Glenmark will consider doing it, I don't know, but it would definitely be a very worthy study.
Thank you. I just wanted to ask one thing, and also I'll first ask JB and Bipin, then you. And what are your comments? The organoprotection like hepatoprotection with GLP-1 RA, or the protection of the gut dysbiosis, autoimmune mitochondrial dysfunction. JB would like to speak about, liver has become very important. Liver
Yes,
diabetes.
so GLP-1 has been studied in patients with non-alcoholic fatty liver, as Dr. Diphonja was saying. It has reduced steatosis, even has an effect on the fibrosis score. There have been shown in the MRI spectroscopy also, that has been shown that also reverses the fibrosis score also. So these are a very good drug, and it's primarily also because of the effect on the body weight loss as well as decrease in the triglyceride level. So the positive effect on the lipid profile as well as the body weight loss, that reduces the hepatic steatosis and improvement in the fibrosis also. So these are very good drug and has been tried in the non-alcoholic fatty liver disease.
Fantastic. I think, don't you feel that the impact on the liver is astounding? And that will be one of the areas which will give much salutary effect to type 2 diabetics, Bipin?
Absolutely. That many of the people, almost 25% of the people in India are having, almost 30% people are having non-alcoholic fatty liver disease, and they are all obese. And we all know that the progression of non-alcoholic fatty liver disease in diabetes and obesity, they progresses much faster to fibrosis and hepatocellular carcinoma. So these are very good drugs in diabetes and obese patients.
Good. Bipin, would you like to attribute to the, the NAFLD people ultimately die of the cardiovascular complication? I think Diphonja has written about it. The CV complication is the end point for the NAFLD. And the GLP-1 RA also has salutary effect on the heart. So that's also a win-win situation. What do you think?
I think both the drugs, SGLT2 inhibitors and GLP-1 analogs, act by reducing weight. They have not reached the stage to get an approval for therapies in NAFLD. And similar is the case with the Indian molecule saroglitazar, which is also a dual PPAR alpha and gamma agonist. So these drugs have good effect. Anything that makes you reduce weight will certainly impinge on hepatic steatosis and early aspects of NAFLD. Whether that translates into an outcome is something which is not yet come through approval by either FDA or EMA. There is an approval for saroglitazar in India for NAFLD. But coming back to the same thing, yes, if you have believe in a different model like adipocity-based chronic disease model, then all these are epiphenomenon of the same thing. That you reduce weight, then you reduce hepatic fat, you reduce the cardiac issues, reduce the renal issues, you reduce the pancreatic fat, and you get improvement all over. So you can expect, but these drugs have not reached the stage that you can get approval for treatment of NAFLD, either for GLP-1 analogs or for glitazones, and for that matter, even for saroglitazar in countries other than our own.
Yeah, fine. We can go to the next center, Abhishek. We have three centers left.
So the next center is Rajkot, and we have Dr. Pankaj Patel, sir, for us. So, sir, please, with your question.
Yeah, my question is for liraglutide. Sometimes some of the patients are not having symptoms of nausea, vomiting, but when we increase the dose, they're troublesome. So, how to overcome the diarrhea in patient on liraglutide?
Person doesn't have nausea and vomiting, Diphonja, but Professor Patel says they may be having diarrhea. So how do we upgrade the dose? Is that the question, Pankaj?
Yes.
Do we upgrade the dose from 0.6 to 1.2 or 1.8 to 1.8?
So diarrhea is relatively uncommon, but it is a side
Sanjay
effect.
sir to be here to unveil the logo. We are about to launch liraglutide.
Lucknow Center, yeah.
Lucknow.
Lucknow?
Sir,
Yes,
please
they are
carry
on
on.
mute.
I think CG has already said you go to Hyderabad now. Hyderabad?
Dr. Ralph can answer that question, sir.
Yes, sir. We'll have that question.
Yeah, this is the question. A lot of people were talking. This is the question on diarrhea. It is true that diarrhea is a side effect, but it's relatively uncommon. constipation is also a side effect, and it's relatively uncommon. Again, I would take the same approach as I take in people who have nausea. You just have to go back to the lower dose where there was no diarrhea, stay at the lower dose for 4 weeks or so, and then try to titrate upwards. I have to say, I've not had this problem in terms of people who have not been able to tolerate the drug because of diarrhea. But then if they do, obviously you cannot progress. You can try things by increasing, starchy carbohydrates, fiber in the diet to try to minimize the diarrhea, things that you would do in any person who has diarrhea. That would be my suggestion. But I have not found this to be a major problem in my patients.
Thank you. We can go to Cochin.
Thank you. Yes, sir. We'll move on to Hyderabad, sir, the next center. Yes. So we have Dr. KVS Harikumar, sir, joining us from Hyderabad. Over to you, sir.
Thank you. Moving from what has been discussed, I'll ask something about what is close to Dr. DiFranzo. The octet, what you describe actually in patients, do you see the individual components of it contributing more or less in a given patient? Number one.
Yeah, that's a tough question.
Number two, does it make sense to actually cluster them as what we looked at the Sweden study? Does it make sense to have a pathogenic cluster? Say maybe somebody is having only liver and say muscle is more problematic, or somebody having a adipose tissue more problematic, like that.
Yeah. Yeah, of course, in the Swedish study, they didn't sort of see where steatosis and fatty liver fit in with the cluster. I mean, to me, the two biggest defects are insulin resistance and beta cell failure. Insulin resistance is, in my opinion, the earliest abnormality that you're going to see. As long as people maintain an appropriate beta cell response, the hyperinsulinemic response will overcome the insulin resistance and you maintain normal glucose tolerance. But eventually, the insulin resistance and the need to hypersecrete insulin leads to progressive beta cell failure. So you do not see a rise in A1C unless the beta cells fail. But obviously what's provoking the beta cell failure is the insulin resistance. So to me, these are the two core defects that you have to treat. Now, importantly, the two best drugs, in my opinion, for treating these are pioglitazone and the GLP-1 receptor agonist. And both of those drugs, the pioglitazone directly corrects the beta cell failure and the insulin resistance. The GLP-1 receptor agonists have a direct effect on the beta cell. Indirectly, by promoting weight loss, which is really very important, they improve insulin sensitivity. So both drugs are either directly or indirectly correcting the two major core defects, insulin resistance and beta cell failure. And those are the two which I think are the most important in the ominous octet.
Great question, Hari. Very intelligent question. We'll go to the last center now. Cochin,
Yes,
we have the onboarding.
So we'll move on to Cochin, the last center for evening. Dr. Vipin VP, sir, please, your question.
Thank you, Dr. DiFranzo, for this wonderful opportunity as well as a great insight to the topic. Now, the question from the crowd is regarding your experience regarding the use of GLP-1 receptor agonist and pancreatitis, how common it is. And second is, if a patient had a pancreatitis like 10 years back, due to a demonstrable etiology like a gallstone, alcohol, he doesn't have any diabetes at that time. Later on, he is presenting with type 2 diabetes mellitus and obesity. Maybe 10 years down the line, can he get the benefit of liraglutide?
Well, first, I would say that if you look at all the big studies, it's very difficult to say that the GLP-1 receptor agonists cause pancreatitis. I would say that's not established. I understand that there is a warning, and I think it is important that you review this warning with your patients. But the number of cases where you can really directly attribute the pancreatitis to the GLP-1 receptor agonist are very, very, very rare. On the other hand, if someone has had pancreatitis in the past and you don't know what the etiology of the pancreatitis is, I would be reluctant to use the GLP-1 receptor agonist. if you had a case of pancreatitis due to gallstones and you remove the gallbladder, then I would not feel uncomfortable. Also remember that that there is recently another new warning in terms of cholecystitis that's been added to a potential side effect with the GLP-1 receptor agonist, and this is another issue which again it's a rare complication. I think it's again something you need to discuss with the patient, but these are not, in my opinion, concerns that would stop me from using drugs in basically all of my patients. But if I had a history of pancreatitis or cholecystitis, and I don't understand the etiology there, I would be reluctant to use the drug. But that's a small, very small number of patients.
Thank you, Dr. DiFronzo. We have gone one round of questions. I was given time up to 9:35. I crave your indulgence. I have exceeded by 5 minutes, but I can see the enthusiasm and the quality of the questions. A lot of questions have been asked on my own behalf, on behalf of about 8,000 plus people who have joined. I offer my sincere thanks to JB, to Bipin, and to you, Professor DiFronzo, for being amidst us. Now, over to the organizers for the unfurling of the molecule which I'm just going to introduce. Yes, Abhishek.
Yeah. So, thank you so much, all the respected panelists, for that wonderful and engaging scientific session. I'm sure all the delegates who are present physically and digitally would have had a great scientific feast after listening to all the stalwarts from the field of diabetes. Now, I may please request Mr. Amit Ajmera, sir, who is our marketing and sales head for Diabetes Care Division, to please proceed ahead and take up the vote of thanks from here. Thank you, sir.
Yeah, thank you very much, Dr. Abhishek. Thank you very much, Professor Ikedas, sir, for chairing the session today. Thank you very much, Dr. Bipin Sethi, sir, Dr. Kanwar, sir, and of course, the legend, Dr. Ralph DiFronzo, sir, for excellent talk and discussion today. I'm also very, very thankful for the August gathering that we have.
Symposium very successful. So now we have a launch
the August gathering of all the moderators that we have had in 13 centers. Dr. S. Parmesh at Bangalore, Dr. J. Kishore at Bhubaneswar, Dr. Jayashree Madam at Chennai, Dr. Vipin VP at Cochin, Dr. Sunil Kohli at Delhi, Dr. Manas Barua sir at Guwahati, Dr. Hari Kumar sir at Hyderabad, Dr. Lodha sir at Jaipur, Dr. Salil Pal sir at Calcutta, Dr. C.J. Agarwal sir at Lucknow, Dr. Manoj Chadda sir at Mumbai, Dr. Pramod Gandhi sir at Nagpur, and Dr. Pankaj Patel sir at Rajkot for gracing the occasion and making this event successful. Sir, Glenmark has always been at the forefront when it comes to reaching the products to the Indian audience, be it with gliptinization, when we brought the cost of gliptin significantly down and made gliptin available, and we call it as a gliptinization story in Glenmark. We also had a revolution story where we made SGLT2 very much accessible to the population here. And we have also taken up the cause of pioglitazone with introducing the combinations of tenelipaio and tenelipaio-met. We are now going a step further, and as we call it as after gliptinization revolution, we are now starting a story of incretinization by making GLP-1 RA more economical and affordable to Indian masses with a biosimilar product there. I would like to quickly unveil, if not more details, I would like to quickly unveil the brand that's going to come, and our team would be eager to take you to all of you with all the details in next couple of months, but at least the brand name will be unveiled today. So may I request a quickie to be played, unveiling the brand name of liraglutide, which we are going to launch very soon. Admin?
Yeah, please, if you can play the teaser video.
While it is played, I would also like to thank Dr. Abhishek, Dr. Anup, Dr. Sachin, and Dr. Hemant Barkate sir, as well as my entire sales and marketing team all over the country who have played significant role, and all the audience that is there digitally connected, as Dr. Das said, 8,000 plus registration, and also about 250 doctors who are present at various centers. I would like to thank all of you for making this event successful.
Because of you, our day is made. Really, we give big hand of applause for the people who have joined us.
Thank you very much, sir, for your kind words. May I have the quickie that can be played?
Yeah, it has come now.
Thank you. So that's our brand name, LiraFit, which is unveiled. Thank you very much once again to all the August gathering that is here. And over to you, Dr. Abhishek, for closing the session. Thank you.
So thank you, everyone. Thank you, Dr. Ralph DiFranzo, sir, for taking out your valuable time or for guiding us all through this scientific session. Thank you, Dr. Ekedas, sir, for giving your valuable inputs and your time, for taking and chairing this session throughout, and for wonderfully moderating it for the entire audience out there. Thank you, Vipin Sethi, sir, for your time and for your excellent speech on liraglutide and on biosimilars. And last but not least, thank you, JB Kanwar, sir, for your wonderful input on the pioglitazone 10-gliptin. Also, I would like to specially mention a very big thank you to all the moderators who have been present constantly at the physical centers across India, and who have done a great job of literally combining all the questions from all the delegates present physically. And in short period of time, they have been able to come up with one best question that can be put up in front of the panel. So let me take this opportunity for a big thank you to everyone, and I may now request that the session ends, and a very good evening to everyone. And good morning to you, sir. Ralph DiFranzo, sir.
Good night.
Good night, sir. Good night, everyone.
Thank you, sir.
Yeah.
Ciao, ciao. Bye-bye.
Sachin, thank you. Thank you very much, all the people who made it possible. It has been an epoch-making meeting. I will again repeat that, with a great impact the way we practice diabetes. Thank you. Bye-bye.
Thank you, sir.
Thank you, sir.
Bye-bye.